Welcome, everyone. We are extremely honored to contribute to the Heller School Spring Event Series named the First 100 Days Policy Conversations at the Start of the Biden Administration. Today's roundtable conversation is a focus on the vaccine equity and efficacy in the time of COVID variants. I'm your host for this conversation. My name is Maria Madison. I'm the Associate Dean here at Heller and Director of our Institute for Economic and Racial Equity. I would like to thank everyone who helped to make this conversation possible, in particular, Monica Jordan, Carrie Harris, and Professors Nandu Kumar and Mike Doonan, as well as our MTS support, Nanan Gordon. Every now and then, we get to pause and try to understand a problem from so many vantage points. Now is such an urgent time, for our destinies are intertwined. We've brought together guests from Boston to India, Europe, and a view on work focusing on low and moderate income countries. Our disciplinary guests include Senator Jo Comerford from Massachusetts. She's also the Senate Chair of the State Public Health Committee, and she also worked on the COVID-19 response team. I'd like to also welcome Dr. Oneeka Williams, surgeon at St. Elizabeth Medical Center. She's also a children's book author, so she's our leading communication expert and assistant professor at Tufts University School of Medicine. A dear and warm welcome as well to Director Sangita Patel, who's dialing in from United States Agency for International Development in India, where Sangita Patel is also the director of the health office at USAID. And a warm welcome to Christian von Stolk, who is the vice president of RAND and co-author of the RAND Vaccine Nationalism study. I'd like to also extend a very warm welcome to Dan Kress, the Vice President for Global Health Systems Innovation at Management Sciences for Health. We are placing detailed biosketches of our roundtable discussants in the chat function, but as well, if you would like more information on these individuals, please reach out to us and we can provide you with additional information. I will ask each of you, the roundtable participants, an opening question, and then we'll move into more of a conversation and follow-up where I hope we ask each other questions. From there, we invite all of you, the participants, to post your questions in the Q&A function at the bottom of your screens. And our apologies in advance if we can't get to every single one of your questions. Please send them to us again afterwards if you would like us to dig into some answers for you. After that community Q&A session, we are going to close by asking our participants, our panelists, to provide their final thoughts. Ultimately, by the end of this session, we hope that we all gain a clear understanding of our interdependence, particularly related to some of the issues that are poignant today, including understanding what the surge in India means for the rest of the world. And that some are viewing that the longer COVID-19 is in circulation, the more it mutates. So we're all in this together. With that said, I would like to start with our first question to Senator Comerford. And Senator Comerford, please describe the rollout of the vaccination program in Massachusetts, some of its strengths and the frustrations, and what was and is the relationship between the legislature and the governor in the procurement and distribution of vaccines. How in particular can we do a better job reaching the most vulnerable communities? Senator Comerford.
Thank you so much, Dr. Madison. I'm just really honored to join such a distinguished panel. Very grateful to you and the Heller School and everyone who made today possible. I'm happy to talk about the vaccine rollout in the Commonwealth. And as you were talking about our interconnectedness, I think what an opportunity this is for me and for my colleagues to really make these not only national, but global connections. So I really appreciate this leadership. So I'll start at a high level as we talk about this. And I just note that the legislature during COVID-19 has been a different experience from legislating during any other time. As you know, I'm sure legislatures are designed to be kind of deliberative bodies. You know, we answer to constituents who elect us to represent them in these deliberations, but the spread of COVID-19 waits for nothing. And as you know, COVID hit the Commonwealth hard, exposing really rife inequities that were already present before COVID, but then clearly exposed as deep chasms and triggering an economic crisis in the midst of a federal administration that wasn't at the time able to marshal the necessary resources. So Massachusetts, like other states on the front line of this, was seized. And so we went into a state of emergency, as did other states. And under the state of emergency, the executive branch is given, and this is Governor Baker, of course, emergency authority. And so the governor has been able to move quickly during this to order, for example, shutdowns or travel quarantine requirements and such. The governor can also exercise authority over emergency contracts without a traditional process. And the legislature, especially in the first year of COVID, played a role, moving to approve budgetary funds and also on certain select pieces of legislation around, for example, unemployment or housing and homelessness, the eviction crisis. So that's a little context. And as we moved into the vaccine distribution, it's important for us to remember that in the Commonwealth, the administration, the legislature had been grappling for nearly a year, as other places had, of course, with a deep struggle to care for those who were ill, generate enough personal protective equipment for workers, bolster drained hospitals, and so much more. So your questions asked about the strengths and frustrations of the rollout. And in Massachusetts, I'll just say one of our major strengths is our knowledge economy, our high tech economy, our robust medical community with really renowned expertise. I will also say that the Secretary of Health and Human Services, Mary Lou Sutters, is really tireless, and she moved into a position of significant authority, running a command center structure put in place by the Baker administration. And in addition, it's really important for us to understand that in Massachusetts, again, like other states, we had in place an emergency management structure that was out of the Department of Public Health, as well as MEMA, the Massachusetts Emergency Management, but I'll stay in my public health lane. After 9/11 and after the anthrax attacks, the Department of Homeland Security began providing funding, significant funding, to set up a command structure. It's under the Office of Preparedness and Management in DPH, and it came down then in layers to communities. And these community structures, if you will, hierarchies, had been planning and drilling and preparing and amassing supplies for really 2 decades. And these were supposed to be scalable and nimble and ready to move in a moment like this. And they were preparing up until the fall of 2020 to do the vaccine rollout. And so we know this as we came into the fall, and then the legislature appointed a joint committee on COVIDness and emergency preparedness and management. So we've had several oversight hearings to get a clearer understanding of what was in place. Because this gets to your second part of the question about the significant challenges that we faced. And again, it's important to understand the context. The state was grappling with, and the administration was grappling with all the ravages of COVID as we came into this vaccine rollout. And I will say the first days, and I'm quoting Governor Baker when he said they were lumpy and bumpy. I would say that they were more than lumpy and bumpy, but I would say that there were significant challenges that people faced, that communities faced, that were varied in number. As the vaccine moved from phase 1, which was more of a limited trajectory to some frontline communities, and that was done actually very, very well by the administration. They set up a vaccine oversight committee, and they prioritized these immediately vulnerable cohorts and high priority cohorts like medical providers and first responders. But by the time it moved to phase 2 and the elders 75 and above, we experienced some significant upheaval around things like a website, which functionality didn't work immediately or well. No centralized list of sites with available vaccine appointments. There wasn't initially a call center option. There were not yet plans around transportation or the needs of homebound. So there were some significant issues, and this was not just the shortage. This was how to access what was at that point and still remains an insufficient supply for the demand. And this went on for some time. And there were, in addition, some communication back and forths, which left at one point hospitals without a sufficient supply, at one point local health without a sufficient supply. And there's that has, I think, resolved in large part. But what I would point to that is an abiding concern is, and it's a chorus of concern around racial equity. Again, when I started, I talked about the chasm of inequities that were present in our Commonwealth along race and ethnicity, along class, along geographical lines. And we understand that during COVID, people of color contracted the virus in disproportionate numbers, grew sicker and died. And so the vaccine, this opportunity for us to prevail, many people were concerned that it wouldn't get to the very same communities in equitable amounts to match the kind of ravages that communities of color and poor communities had faced. And so many people across, all parts of our Commonwealth raised voices together for a focus on equity. And the administration, and there were legislators writing pieces of legislation around this. There were advocates raising their voices from communities, from the medical community. And there is now an equity initiative in the Commonwealth, which is, I think, gaining ground. However, there is still a divide between white residents of the Commonwealth and people of color in the Commonwealth and their proportional access to the vaccine. So this is something that, I know that the legislature, I know that the administration cares a great deal about, but it is still a really, really significant concern. And I will say, finally, I'll just close with how can we do a better job reaching vulnerable communities? And I'll just offer 3 quick thoughts. The first one is actually sounds quite simple, but first and foremost, I would say that what we needed from the outset as a Commonwealth was a targeted, transparent, well-resourced plan to break down barriers to access, sort of a shared understanding as a Commonwealth of how we were going to do that. The state did this well with nursing homes, as I said earlier, that phase 1, there were targeted plans where we understood where we would surge resources. But when we got to the general public, we weren't able to have a shared understanding about the allocation of vaccines and how different cohorts or regions or populations would be prioritized and the kinds of channels that would be mobilized to reach these cohorts. And so I do think that in times of emergency, that kind of communication really needs to be paramount. There's also been quite a lot of conversation about the really needing to retrench into an understanding that local delivery is best for vaccines. At a recent hearing of the legislature on variants, Dr. Paul Bidinger, who is the director for emergency preparedness at Mass General Brigham, was talking about the delivery of vaccines and maybe the delivery of a booster should we get there. And, it was talking about the fact that local public health and the local public health infrastructure really is the most effective way. It's closest to people, people understand it, people know and have trusting relationships. And so that is quite important. And what's true is in Massachusetts, we do need to bolster local public health. The legislature and the administration has grappled with this, and I think it's going to become front burnered in this session. And I think that's quite apt for our Commonwealth, because we are only going to be as strong as our local foundations will let us be. And our local public health folks have been on the front lines and can do the job that needs to get done. And then the last thing I'll say is that, really lots of folks are talking about this in Massachusetts now. We need to really shift completely, a culture shift in Massachusetts, and that puts racial health equity writ large at the center of everything we do. You have to look at the social determinants of health, those things that make us well and keep us well, and do everything we can to allow them to inform the kind of decisions that we make now and going forward. And I think that'll be on everything from the kind of policies we put in place so that we build back better from COVID, recognizing the health disparities that were so evident, so painfully evident, and exist as painfully evident now. And we put that kind of forward look to really create a whole different cultural understanding of health equity as an organizing principle for budget and policy decisions. So I'll end there with my thanks again.
Thank you so much. That was excellent. Not just what we're facing today and not just how we can get back to normal, but you describe a new normal, a normal that creates equity. And you also touch on the importance of the local context. And so with that in mind, Dr. Williams, there's quite a bit of debate about what's occurring at the local level. And a lot of people like to describe it as an issue of trust, that uptake is problematic related to trust. Others are saying it's really about dignity, which goes back to what Senator Comerford was describing when centering issues of equity, racial equity, and the social determinants of health. So in essence, there is a lot of discussion around mistrust and hesitancy about COVID, and based on various aspects coming out in the media: religion, political stance, fear of over-intrusion of government actions, concerns about violating basic human rights. There's a feeling that the goalpost is constantly being moved by the administration, and the news about issues with the Johnson & Johnson and AstraZeneca vaccines have only added to the confusion and undermined trust. Can you provide your perspective as a clinician on these issues, and what will help to build equity in not just addressing the current multiple pandemics, but going forward?
Part of this conversation, and I welcome the opportunity to share my thoughts. I would really, kind of starting from my perspective as not just a surgeon and an author, but someone who really uses story at the forefront of how I communicate with patients, because ultimately communication and really understanding of the issues is paramount to making decisions that are informed and that align with potentially best outcomes. And I'd like to address this from sort of three perspectives in relation to the questions that you asked. One is the rights of the individual versus the collective, and the collective is not an either or, it's a both and. And so I really welcome this conversation about us as being interconnected. The second point that I'll make is that, we're in a war and there are only two sides. It's us and it's the virus. And so I think we need to reframe looking at that very carefully. And then the third point that I will address is, especially from a clinician and a scientist perspective, is really resetting the expectations of perfection that comes out of really scientific discovery and how we use that to inform growing trust within the community. And I'll shed the equity lens as I go through. But if we really go through to this concept of individual versus collective rights and realizing that this tension between public health and personal liberties is not something new. This has been ongoing for centuries and really speaks to, as we became much more industrialized and infectious agents became much more prevalent, how do you really kind of manage this tension? And I think about it, if I come and put on my clinician's hat, and I think about what do we as clinicians deal with most when we think about interconnectedness and an ecosystem. The body is the best, I think, example of that. And so when we consider regulation versus freedoms, I'm a urologist, I'm a urologic surgeon, I operate on the kidneys. And so what if the kidneys decided that it did not want its blood flow to be regulated, that it just wanted to have carte blanche over how blood flow flows through the kidney? What that means is that in actuality, in essence, not only will the kidney be destroyed,
Hi.
but
Hey, Brian, how are you?
Good. I was just listening to Joe too.
Oh, good. You're on.
Sorry, Joe, you're
Yeah,
unmuted.
I was just in the back. I
Joe?
was just
Thanks. Sorry, Dr. Williams.
yes. And so in actuality, what happens is not just the kidney is destroyed, but the entire body suffers. And we have to have a central controlling agency that really helps in the coordination of all of the aspects of the body. And that's our brain. Our brain is essentially that central command. And there are times that the brain, like the government, may be diseased, but in actuality, there has to be some understanding that there is a central body that helps in this coordination. And if we don't have that, then it really becomes anarchy. And I think if we look at the COVID response, we look at those countries that did not look at the wearing of masks or social distancing as an impingement on freedoms and personal liberties, but actually a necessary regulation for the greater good, and that the communities as a whole embrace that, then we saw that those countries actually had much better, kind of overall control and disease management within their communities. And so I think that we really have to think about this kind of personal liberties and collective, what is the collective good as kind of a seesaw effect, which is that there are going to be times when we may have to compromise a little bit on these kind of personal liberties in order to achieve the greater good. And it's so difficult to make decisions in the face of uncertainty. When we looked at what was happening with COVID, we were faced with a situation that we have never encountered, certainly within this generation. And having to make decisions about how we do that and how we respond in the setting of evolving information really created a huge challenge. And so we had to make decisions around weighing what was kind of personal benefit and individual liberties compared to really the potential for grave harm. And so I think when we think as a collective of the importance of that understanding, I think it helps to inform in a much more, I think, effective way that the decisions that were made and that are having to be constantly made around how do we really shift the thinking from this real personal pursuit, independent pursuit, to this interconnectedness and what is at the greater good for our communities and for our world, it begins to change, I think, how we really perceive these things. When we really think about sort of this moving goalposts, and that the government moving the goalposts, the vaccines moving the goalposts, at the end of the day, the only goalpost that is being moved is the virus. I mean, the virus is moving the goalposts. Every time we think we understand something about the virus, the post moves. A new variant comes out, a new mutation is identified. So we are dealing in a constantly evolving and changing environment and landscape as it relates to the virus. And we have to really identify that as such. If we are in a war and we are fighting a war together against the common enemy, I think this is probably the first time even in our immediate history that has become, that we have a common enemy that the entire world is fighting. However, we're not accustomed to uniting together against a common goal. And so what we find is that we have now had to create an army based on factions that have been warring. When we really think about Black and brown people being on the front lines, showing up to fight without the necessary tools, already behind the 8 ball because they're missing limbs, they don't have the appropriate armor, they don't have the appropriate equipment. And we are on the front lines doing that work. At the same time, we're asking us to come together as a collective, to communicate as a collective, to put aside all of the things that have really impacted our abilities to come to common ground in many areas, to be able to gain a common perspective and a common approach. And that in itself has been extremely, extremely difficult. And I love what Senator Comerford really said, is just that, we have to begin to really view this war through a number of lenses. And certainly the lens of health equity is extremely important, because we're only as strong as our weakest link. And if we do not have an opportunity to make sure that we are protecting and we are caring for those within our communities, to ensure that equitable access and equitable health and equitable outcomes, and really doing away with the type of disparities that are related to the social determinants of health, what we end up with is really a structure where we have significant weakness within what we are able to do, because we just have not ensured that all members of our community are strengthened to be able to face the daily challenges with the same degree of resources as others do. So we have to be very mindful of this war. And then the third thing that I would say, in terms of when we reset these expectations of science, science is absolute. It is as vast as the universe. The thing that is really changing is our discovery of the science. So our discovery and our understanding of the science is limited. Our science is just this huge, huge entity. And the science itself doesn't change, but we are constantly on this road to discovery. And I think we have to do away with this facade of perfection in so many areas of our culture that we aspire to. And we have to look at this from this perspective of this science is constantly, our understanding of the science is constantly evolving. We're dealing with information that is becoming more and more clear as we gather data. That's what science is. It allows us to observe, it allows us to experiment, it allows us to apply the data as we accumulate it. So even from a perspective of vaccines, we understand why vaccines are effective. We understand why herd immunity is necessary. We understand why the rollout has to be done in such a way to be able to achieve the appropriate outcomes. What we don't know is that when we have a virus that is constantly changing, and we've never had to address and to basically generate and create a vaccine in such a short period of time, we have to accept and acknowledge that there's going to be learning as we go along. As we acquire more data that helps to inform how we move forward. And so I think that the communication of this is so incredibly important that we have to reset and reframe how the population thinks about what these vaccines offer, how they were developed, the incredible, I think, amazing outcomes, really, when you think about in terms of the progress and the process of scientific application and medical treatment, that we have literally within a span of a year developed vaccines that have 95% efficacy. Now, that's not 100% efficacy. There's still 5%, which means that there's still going to be some breakthrough infection. But what it means is that in a world where we have not had that type of vaccine efficacy, the flu is not 95% effective, we have applied, unfortunately, a set of standards to the COVID vaccine that I think has resulted, because of politicization, because of just communication and marketing that I think was misinterpreted and communicated probably not the most effective type of message. But we have to really acknowledge that we have made significant strides, that we're still learning, and that at some point we have to be able to trust that the process is going to bring us along a path to help to really gain control of an entity that will devastate this world if we do not acknowledge that we're not going to get to perfect. We're going to be learning along the way, but what we have so far is certainly much more preferable and much more effective than literally laying down our arms and saying, that we're not going to do anything because we haven't had 10 years to develop the type of data that makes us feel more, quote unquote, comfortable that these vaccines are going to do what they're designed to do. I think that we have to trust. And what are the things that we need to do to trust? I think we have to have these type of conversations. We have to bring these conversations into the individual interactions so that, as you said, as Senator Comerford said, the community health approach is extremely important, especially for Black and Brown people. Being in communities where you trust, where you believe that your best interest is at heart, where you believe that there's not a layer of unconscious bias or some historical context that really informs and somehow taints the information that you're being given. And so I think all in all, we do have an opportunity to really make a significant stride if we're able to really elevate the conversations, continue to really bring them into our households, into our doctor's offices, into our community centers, and really develop the type of narrative that does not hold what is the scientific discovery and the scientific process to a completely unrealistic standard.
Thank you so much. That was profound and beautifully crystallized the battles within the war that we are fighting, not the least of which is the individual rights versus the collective perspective, not the least of which is sharing science in order to increase trust. And, you know, after we hear from everyone, I certainly want to circle back right now. Today, one of the biggest transparency questions related to science is what's behind the J&J pause, for example, and what that means for risk benefit. So I'm going to post that question in the parking lot, if you will, and we'll circle back around to it. But so much of what you said also, even though it's local to us right here in Boston and Massachusetts, from both your words and Senator Comerford's, really relates to how India has really taken on a lead in addressing this global pandemic. So I want to turn to you, Dr. Patel, India, you know, has been at the forefront of developing vaccines, a rapid internal rollout, and India's been a key player in making vaccines available globally. Can you speak to, you know, USAID's experience with India on these?
Absolutely. Thank you so much once again for the opportunity. Really appreciate Brandeis University and all really that the team there has actually done, even for the team in India. Frankly speaking, the role that we have had to play within this space as USAID is really attributed to the strong collaboration that we've had with folks such as Dr. Nanda Kumar. I can tell you for a fact that my team has been grateful, and certainly I have too. Within the current Biden-Harris administration, the top priority that they have outlined, and is very aligned to the theme that you've presented these first 100 days, it really has been about saving lives and ending pandemics. And I know that there's a long road ahead of us, especially as you look at India today. We have a global challenge. Earlier, you presented an image even of the world. What happens in India often foretells what will happen in the rest of the world, simply because of the sheer magnitude of people that are here, the 1.37 billion people, and really the need to be able to control or get a quick control on the pandemic. And what we have found certainly is that the United States president is deeply focused on this issue and being able to expand global vaccination and manufacturing capacity and delivery, and really look to India as a partner to be able to do this kind of support, particularly in relation to COVAX and the rest of the world. For the United States Agency for International Development, we've certainly enjoyed being a part of the early planning and really thinking through what can we do as part of a vaster interconnected community, as you presented earlier, whether it's the United States, Japan, or Australia, and India. There's certainly a huge role that we can play together when it comes to vaccines, production, equity, and really working across good multilateral, transparent institutions that can ultimately support across the world equitable access. So right now, at least in India, we've been very grateful again for the partnership with Dr. Nanda Kumar and team, and really being able to think through even innovations. How can we expand diagnostics? How can we support therapeutics, even combat disease, and be able to strengthen really the public health response, the comprehensive primary health care, and also be able to forge our way into the manufacturing space and even address supply chain shortages. So we've certainly been able to create or at least structure a national, at least a blended financing facility, ultimately to be able to pool resources across foundations, across the private sector, across corporates, like-minded, interested individuals really wanting to generate to the cause and ultimately be able to fill a gap that's needed in critical care, in diagnostics, and especially when we saw the first and now the second surge, those higher levels of care. So we are very much looking forward to progress in this arena and being able to move on market access and innovations with these additional resources in partnership with the government of India. I know for a fact as well that certainly Prime Minister Narendra Modi has announced since January 16th, India's really large vaccination drive. Their need to not only administer dosages across India to the hundreds and millions across the country and the nation, but also to really look to the region and really see, as you mentioned earlier, Myanmar, but neighboring countries. The Indian government has talked about vaccine maitri, which is really friendship. And for them, it was about making sure that they're part of humanity, that they recognize, even as they face the most difficult pandemic internally, they're also opening doors externally and ensuring that on both fronts, that they treat both and that they're actually able to, with respect, attempt to support both. I think this is why USAID and other partners are so committed to working together, because it's just not going to happen through, one government or one nation alone. And I think for us, at least, we've been excited to support, even from the bilateral end, a stronger partnership between the US government as well as the government of India, really to be able to bolster the COVID-19 response, to be able to support infectious disease control, and certainly strengthen the health system, the response, but also even look at that space of vaccine deployment and how we can be able to together, in partnership with COVAX, be able to support even the need for equitable access across the world. I think that similar to the United States, the program in India really has been striving to make vaccines available. And it's been, just as you heard Senator Comerford describe, it's been a tiered approach. They've been looking at being able to support the most vulnerable, whether it's the front line, the elderly, and then on down in terms of tiers. And right now, we're excited that soon the vaccine will be accessible even after the 1st of May to those that are above the age of 18. So for us, at least, this is a huge call to action, particularly at the primary healthcare levels, to be able to ensure that vaccinations are accessible, available, that we're supporting, at least in this response. For us, the vaccine program is a terrific example, really, of partnerships, of how we work across the public and the private sector, and really of how we pool even the needs across civil society. I know that we also heard a little bit about working with vulnerable populations. USAID has certainly been proud of even working across a new COVID action collaborative, really comprised of over 300 some individual civil society organizations, primarily meant to be able to reach the most vulnerable, particularly because we know that when it comes to COVID-19 access, whether it's the United States or other parts of the world, even in India, we face similar issues when it comes to indigenous populations, when it comes to even those that are poverty-stricken and those that are marginalized. And so we've made extra efforts to be able to reach them and to be able to fold them into the circle, really the continuum of care. I think from our end, we know that India is often seen, especially as the pharmaceutical, capital, if you will, of the world. And so from our end, we've certainly realized the central role that success in India not only plays on a domestic front, but on an international front. We'd like to see success on both levels, ultimately, because as you so poignantly described earlier, it's an interconnected world. And whether it's COVID-19, climate change, or really, frankly speaking, so many of the other complex challenges that we're dealing with, unless we work together and work in partnership, we certainly won't be able to get there. And I know that my team and I have been able to at least really enjoy the collaboration with Brandeis, with Dr. Nanda Kumar, and certainly with really across multiple private sector and foundation and government partners to think through what can we do? How do we be more resilient? And how can we, at an operational level, adapt? Because that's what it's taken. It hasn't been the traditional response. We've had to find new and creative ways to be able to reach people and ultimately to be able to bridge that divide. Thank you.
Thank you so much. Again, absolutely profound demonstration, especially through your words, of the importance of partnerships, given the absolute compelling status of COVID within countries, still assisting with other areas around the world with supply, vaccine supply. And so you can't do that without partnerships, without recognizing that this is a global issue. So thank you so much. And related to the concept of partnerships, I'm going to move over to you, Kress Van Stolk. In particular, Europe appears to be lagging behind other countries in the rollout of vaccines, and it also appears to have relied very heavily on one vaccine. The uptick in cases is leading to more lockdowns, economic pain, and discontent amongst the people. Can you describe the current situation as from your vantage point of Europe, the situation in Europe?
Yeah, thank you, Maria. I think it's probably important to give a little bit of context before we get to the current situation. And I'll take you back to what Europe decided to do and why that was important. And it was pretty clear from the outset that Europe was going to choose a central response to the crisis. And the idea was that obviously Europe has more market power as a collective. And so they decided that vaccine procurement would happen at a central level. So that made sense. Europe has more market power, so that way it could procure vaccines much more effectively. However, there were a number of different problems with that. The European institutions that were going to support that have very little statutory responsibility in the field of health. Health is a national responsibility of the member states. So that is the first problem. The second problem was that the European institutions that were going to support this have very little procurement experience, particularly in this area. So they were working at a slight disadvantage. And also the approach that Europe chose was less aggressive than the United States, for instance, or the United Kingdom, in the sense of they were more hesitant about which vaccines might be effective. They didn't want to bet on one particular vaccine alone. And also some of the contracts that they negotiated with the pharmaceutical companies and vaccine producers at the time, and these were all at that time we didn't know which vaccines were going to work, allowed the European Commission some wiggle room in terms of procuring those vaccines, but also on the other side, allowed the pharmaceutical companies some wiggle room as well. And then on top of that, there was also a process of bureaucracy. There was a lot of bureaucracy involved in putting this in place. And of course, bureaucracy takes time. And there's good reasons to have that bureaucracy, but in this case, that sort of backfired. So it led to the interesting situation where a continent with such capacity to produce vaccines, in fact, at the initial stages of vaccines being available, were mostly exporting those vaccines to other countries. And that became politically quite difficult, and I will get into that in a second. A second factor was Brexit. All of you will know that the United Kingdom decided to leave the European Union. One of the leading vaccines was, of course, the AstraZeneca-Oxford vaccine. Now, AstraZeneca is an Anglo-Swedish company. However, the vaccine was very much seen as a UK vaccine, and also was touted as such by the UK government. And this was also politically difficult for the European Union. They didn't really have a domestic vaccine or a domestically produced vaccine that they could count on. You had Pfizer, Moderna, you had AstraZeneca, but not really the European candidate as such, although you could argue that the Pfizer vaccine was also had German, very strong German partnership in it as well. Now, the politics then sort of started taking over. There were fights with pharmaceutical companies. Politicians felt that the pharmaceutical companies were not delivering on their commitments. So there was some of that. There were export controls that were being conceived. So stop exports of vaccines to allies, really, of the European Union. And countries affected, there were the Australians, for instance, but also the United Kingdom. But more worryingly, perhaps, politicians started raising questions about the efficacy of some of the vaccines as well. And some of that was done potentially on purpose to sort of put pressure on pharmaceutical companies. But the result of that was that trust in those vaccines was eroded quite quickly in some of the societies and polities in the European Union. The other factor was that communications were often quite contradictory. For instance, politicians stated, typically politicians, but also regulators stated that for instance, the AstraZeneca vaccine was not effective for people over the age of 60. And then subsequently, almost a month later, would say the vaccine is effective for people over the age of 60 and should not be taken by younger populations because of the clotting issues associated and rare occurrence of clotting issues with this vaccine. Now, if you're a citizen in the European Union, this is all rather confusing. And on top of that, we have the issue of vaccine skepticism. We should not underestimate that there is quite significant vaccine hesitancy or skepticism in our European countries. France, for instance, I think there was some polling to suggest that only 40 to 50% felt that, and this was even before some of this controversy, felt that they would benefit from having the vaccine, for instance. And again, that is a huge hurdle to overcome. This skepticism, sadly, is the highest among some of the ethnic minority groups as well in the European Union. So there are also very particular groups that are affected most. So we see that take-up in those groups tends to be lower, and I assume this is something similar that you might see in the United States and in other parts, tends to be lower in some of the minority groups and migrant communities. So there's a little bit of background. The situation at present is improving quite significantly because, of course, Europe in the end will get its house in order. The production of vaccines are being ramped up and being distributed. But the legacy of this plays a very significant role and means that European countries are months behind the United States and UK. Being months behind, of course, also means the following, is that new mutations might emerge, but also more deaths are incurred and more economic costs. So all of this comes at a tremendous cost. A final issue I was going to raise, which I think is important and we haven't touched upon today very much, is Europe is a continent of free movement, similar to the United States. Now, how do you ensure that free movement can start again? And of course, in Europe, we have many more travel restrictions than in the United States. Well, the answer seems to be some form of COVID certification, where you can sort of certify your status, or some COVID passports. The issue, of course, with this approach is that there are very significant inequities around this. What happens to populations that haven't been vaccinated yet? And typically in Europe, we have chosen an age-based vaccine rollout. So younger populations have not been vaccinated. So does it mean that younger populations cannot travel when older generations can start to travel again and have rights that younger populations cannot have? And keep in mind, these rights might be extended not just to travel, but also to visiting nightclubs, going to restaurants, and so on, as you, for instance, see in Israel. The other aspect, which is also uncomfortable, is that if take-up is relatively low in certain groups, and if those groups are ethnic minorities or, for instance, low-income groups, what does that mean to overall equity in society as well? Are we reinforcing some of those aspects as well? So Europe has not had a particularly good crisis from my side. I've explained some of the factors why that is. It's getting its act together, but I think many of the sort of issues and factors that I've mentioned leave a certain legacy, and it's interesting to see how we manage that legacy going forward. So I'll probably leave it there, Maria, and I'll be happy to engage with further questions.
Thank you so much. A million questions in all of our heads as each of you speak, not the least of which is that is a powerful warning from legacy, leaving us with a low percentage of the European population getting vaccinated, and then requiring or discussing and debating the issues then of the equitable requirement of a passport or certification. Those contribute, as you said, in profound ways to the pace of mutations and deaths. So we have a lot of work to do. I have so many questions on how do we get there then, but we're going to move next and hopefully have a little time for you to ask each other some of these profound questions on how do we address legacy, particularly with that profound potential impact of increased mutations and deaths. We're going to move over to you, Dan. In particular, COVID has starkly highlighted our global interdependence as we've been speaking, and we began in Massachusetts and around Boston and then moved over to India and Europe. COVID has starkly highlighted our global interdependence, and yet ensuring equity and access to COVID vaccines across and within low and moderate income countries remains a major concern. There's criticism that nearly 80% of the global vaccine supply has been locked up by high income countries. Can you describe what steps are being taken to ensure the financing, procurement, and distribution of vaccines to low income countries? And what can we do better in increasing access to vaccines to those most in need? Not an easy question.
Dr. Madison, thank you very much for the question, and thanks very much to you and the whole team at Brandeis for inviting me to be part of this panel. It's a pleasure to be able to be with you and talk about these issues. So you're right. I think in a way, I think the situation for the rest of the world, particularly for the developing countries, is it mirrors in many respects some of the challenges that Dr. Van Stolk just talked about from Europe. And so I think that the current situation, if you look at it right now, what's happening in terms of the global vaccine distribution, or about 50, there's been about 8.6 billion doses purchased so far. About 53% of those doses have going to high-income countries. The amount that have been actually purchased by COVAX, which I'll talk a little bit more about in a second, is about 1.12 billion. So obviously, there is this picture right now. It does look pretty inequitable, and so there is a cause for concern. But I think I think in the spirit of, I think there is some good news here, and the situation is really, I think, is rapidly improving for the low-income countries as well, and for the rest of the world, frankly. And part of the reason it's really, I think there's reason for optimism is COVAX itself, the facility that was sort of created in record time, building off a very much a collaboration by CEPI, the Center for Coalition for Epidemic Preparedness, with Gavi, the Vaccine Alliance, WHO, UNICEF, and then obviously with the support of a lot of bilateral and multilateral partners, and frankly the pharmaceutical, the vaccine industry. So they've really been able to, get COVAX, this facility, up and running in record time. And I'm not going to go into the details of how COVAX is organized, but it's probably easiest to think of it as it's trying to do several things. One is it's kind of a pool purchasing mechanism, which is really trying to kind of make the demand more visible and predictable. It's also partly trying to come up with a fair distribution framework for how the vaccines would be distributed more equitably across the world, and they've got a good framework for that. It's also trying to create a mechanism for an advanced market commitment, like they have for the pneumococcal vaccines previously, to ensure that there's some purchasing power or subsidies for low middle income countries to be able to kind of increase affordability for them to be able to purchase the vaccines. And they're also doing things in terms of providing support for cold chain equipment and distribution, et cetera. So COVAX is really an incredibly important part of the architecture for global vaccine equity. And I think there is, there is definitely some good news. Is COVAX is making a big difference in this on this challenge, and I think that is going to continue to make more and more of a difference. So I think there's some reason for optimism. I think one of the other reasons for optimism, a little bit, or at least some good news, is that the global vaccine supply capacity has really increased quite dramatically. Pre-COVID, you had anywhere from a global supply capacity of about 3.5 billion to 5 billion. Of that 5 billion, about 1.5 was for flu vaccines. But that's, right now, current estimates are that the global vaccine supply capacity is around 10 to 11 billion doses, maybe even a little bit more. I guess a question one might ask is, well, how much do we need? And again, sort of slightly the good news is it looks like we need around 11 billion doses, which is about where we are with the supply, because that's we have a global population of about 7.8 billion, rough estimate of herd immunity of around 70%. That means we need about a population to be vaccinated of about 5.5 billion. Double that for a 2-dose vaccine, that's about 11 billion doses. So 11 billion doses is what we need. We have a supply for about 11 billion. And again, there's a lot of and a point I'll come back to. There's a lot of fragility in this system, and there's, because of a couple things could go wrong, and we could really be in a bad situation, So what are some of the things that we need to be able to kind of have any success around global vaccine equity? I think there's a whole bunch of things, really. And I think one of the first is we need some success on the vaccine development front. Some of the capacity is really tied up in some of these vaccines, like Novavax and the vaccine that Sanofi GSK are producing, that have not really fully gone through phase 3 trials and been approved for use. And so we need those vaccines to be successful so that we add more tools to the toolkit. One of the other things that we need for global vaccine equity really is financing. Financing. So COVAX needs at least another $2 billion, probably quite a bit more, particularly to be able to increase some of the financing for the 92 COVAX AMC countries. I think we're going to need the multilateral development banks to step in. For both some of the IDA eligible countries, we're going to need them to step in with some of the IBRD type funding. for some of the middle-income countries and low middle-income countries who have an ability to kind of take on some additional financing for a whole host of things, whether that's supply chain, distribution. So we really need the financial architecture of the multilateral development banks to step in. There's even been some proposals around having the IMF issue some additional special drawing rights, or SDRs, to create some additional liquidity that developing countries can then use to be able to kind of get access to more foreign exchange, to be able to again finance some of the inputs that they need to be successful on this. I think one of the other things that's really going to be critical is dose sharing, dose sharing agreements. If you look at because as Dr. Van Stolk mentioned, the U.S. and Canada and several countries really went out. They prioritized speed and placing multiple bets, right? And they were willing to put some money on the table in order to have. And so, Canada looks like 5x. It's 5 times the amount of doses that it needs to vaccinate its population. Switzerland is 4x. UK is 3x. The US is 2x. So there's it looks like there's going to be a lot of extra vaccines, and there's probably 20 countries that are in the category of 2x their vaccines, and so dose sharing is going to be really, really important. I think one of the other things is this is that fragility. There's the supply. Vaccine manufacturing is quite complicated and technically demanding. It requires a lot of inputs, some of which are globally in short supply. And so some of these supply chain issues really need some careful attention. And there's been some issues that Serum Institute of India, which is one of the largest vaccine manufacturers, certainly in India, if not even the world, has been, I think, been concerned about the availability of certain inputs that it needs to supply vaccines that have not from the U.S. And there's been some concerns that they've not been able to get those inputs, and so that's an issue. We're also going to need this increase in technology transfer from from some of the more advanced vaccine manufacturers to some of the manufacturers in middle income countries, to be able so that they can have the know-how to make some of these new vaccines, which are technologically complicated. Cooperation across nations is another key ingredient. A lot of this, there's been discussions about kind of vaccine hoarding or hoarding of inputs. So we really need that kind of global cooperation to kind of make sure that everyone's successful. In many respects, one might even argue, we need India to be successful in managing its surge, because that will actually help, ensure that vaccines can get out to the rest of the world and as well, because they are such a critical supplier globally. One of the other things is, and this is, my organization, which ironically enough is headquartered it was founded out of the Boston area. So we even have a connection to that area, has been working on, helping countries introduce and scale up some of these vaccines. And there are a lot of problems that countries have had with trying to, make use of some of these new vaccines. One of the things we had to do in Ukraine was to kind of arrange, which was supposed to get some Pfizer vaccine, which, as many of you probably all know, requires an ultra cold chain, and so had to arrange for to ensure that cold chain was available and that there was a process in place. And so my organization was helping the government there to put in place some arrangements so that verifying and then ultimately putting in place some arrangements to make sure that they could actually get the 117,000 doses of the Pfizer vaccine. They could store them and distribute them effectively to get them out to the people. I think one of the other things that we really need globally for global vaccine equity is, frankly, a little bit of luck around the variants and the boosters. Because if all of a sudden we have to start, producing boosters and new formulations to target some of these variants, that's going to have an impact on vaccine production for the high-income country world. and that will likely have a negative consequence for the rest of the world. And so we do need a little bit of luck on that, because it's when you look at it carefully, the situation is one where, it could, with a little bit, it's a kind of a knife edge stability situation where if a few things go wrong, the supply conditions could be quite acute. So we need globally a little bit of luck to get through this. So over. Thanks very much.
Thank you very much. That's a wonderful summary for everyone, which is this combination of guarded optimism combined with a realistic view of what's currently happening, along with the very realistic concept of luck and the role of luck in us being able to work across nations. As you put it, cooperation across nations is essential. All of the conversations have been immensely helpful. We have a couple of questions in the Q&A. So I'm going to ask my colleague, Professor Nanda Kumar, to read some of those questions, and then we'll ask for each of you to provide your final thoughts after hearing each other, and then we'll close by 1:30. So we'll do Q&A for about 10 minutes. Professor Nanda Kumar, and then
thanks.
Final comments.
Thanks, Maria. So I'll kind of bundle these questions together. The first question is for Senator Comerford and Dr. Sangita Patel, because it really talks about the question of if we wanted to put racial justice and if we wanted to put equity at the center of the future of how we think of responses, not only to the pandemic, but to health systems, what does it mean in practical terms? So that was one question. Senator Comerford first, and then Dr. Sangita Patel after that.
Sure, thank you so much, Professor. So this is a terrific question. I will say that there have been many, many racial justice advocates in the Commonwealth that have asked similar questions, and over the years have worked with public health cohorts of policymakers and thinkers. There is a piece of legislation pending. It's called, to actually address this in very, very pragmatic terms, it's called the Health Equity at All Levels in Government, or HEALING. This has seen its way in the legislature in iterative terms, put forward by numbers of legislators over time, really trying to grasp the complexities of racial health equity and how to implement them responsibly. I should say that I have the honor of having this bill this session, but it's just, I stand on giant shoulders. And it's also, this legislation has really informed this session in a response to COVID. What's a responsible way that we would go forward in the legislature, knowing what we know now, as we emerge from this past chapter. So this legislation, again, is quite large, and it's gotten more and more complex as it's been filed. But basically, it's in two phases. The first phase is a culture change, and it's actually it prescribes 3 years to build a knowledge base, infuse health equity into government culture, and it stipulates a lot of different steps to do that. And then in phase 2, it actually shifts. It shifts responsibility. It after building the culture and capacity, it actually shifts outward to agencies and then to legislators. And it's accomplished by instituting new mandatory processes that require agencies and the legislature to consider health equity in their decision making. So it is held accountable by an interagency task force, an oversight board that coordinates the different agency heads and a legislative body. I'm happy to talk more offline and send fact sheets to whomever wants, because we really, after having many, many conversations over this development phase, what we understood was this 1-2, if you will. One is we have to change what we think, really change how we view the importance of health equity, put it at the top as an organizing principle. And to do that, there needs to be a scaffolding of capacity and calls to action. And then we have to shift around government and take health equity out. There is an Office of Health Equity, but take it out of where it is under many layers of government, and put it up into the executive as a co-equal organizing force, and ask the government to really understand that everything we do, every action we take of significance has an impact on public health and on racial equity. And together, we need to actually reorganize what we prioritize in the name of this, what we would hope to be an organizing force. So it's a I'm not saying it's an easy pass bill, but I will say that post-COVID, the kind of awakening that we see and the kind of public pressure that we're rightfully feeling, I started by saying that we're held accountable by constituents. Our constituents are mad, and they should be mad at what we've just experienced. And so they want something in return. So whether it's this bill or another organizing principle, something has to shift in the way we do business in the Commonwealth. And the legislature has appointed a racial justice committee for the first time in our operating. So now there is a racial justice committee that's a co-equal joint committee with all the others. So we see some movements, and I'll stop there. Thank you, Professor.
Thank you so much. Thank you. Dr. Sangita Patel, your take on this, please.
Thank you so much, Dr. Nandakumar. I think that from our end, certainly what we've seen in India really is that COVID-19 has really brought to the forefront a lot of chasms, if you will, a lot of fragility that already existed within the system. And I think what we learned especially is that whether it's access to vaccines or whether it's access to just basic health services, it's certainly highlighted to us that there are populations that are often left out, whether they're the extremely impoverished, the marginalized, those even post, COVID, and even post nationwide measures of a lockdown, where they felt really a lot more pressure than others. I know that since March of last year, even when India imposed one of the largest nationwide lockdowns for 2 months, a significant amount of people were impacted. Millions, at least 112 million. At least jobs were impacted. We knew that those were especially hardest hit among daily wage earners as well as women. And so when it came right down to it, it was an eye-opener for our team and certainly even for the government. And it really actually launched a series of measures across really the private sector, across the government of India, across donors and even partners to figure out what can we do in this, deplorable gap that's been created, these seams that we've seen. How can we actually, heal, right? Because ultimately what we find is that it all comes down to, a sense of humanity and understanding that no one should feel that even within a pandemic situation that they have any less rights or access than others. But we know the reality is that the situation unfolds in a different way. I think that is why certainly from our end, we've invested in programs to reach the marginalized, to reach the vulnerable. And I think especially with the latest measures, certainly from the US government, USAID, HHS, and other agencies, we've looked towards how we can at least influence this environment by making sure that, I think as said earlier, we can help not only on a domestic front, but actually think in terms of how can we bolster India's capacity to manufacture and really meet that global, supply and demand equation. And from our end, certainly the US government has pledged an initial $2 billion out of a total planned $4 billion to support the purchase and delivery of COVID-19 vaccines to at least 92 low and middle income countries through COVAX. And I know that with our partnership with Gavi and at least being able to ensure even strong collaboration on a bilateral level with the government of India, we do hope to ensure that these vaccines are accessible and available to the world's most vulnerable. But we've also got to make sure that we do look at India domestically as well, and ensure that we prevent this next surge, or at least control it. I think from our end as well, we've launched programs, particularly in urban health centers, where we've really looked at how can we, at an operational level, facilitate the deployment of vaccines and really be able to combat things like vaccine hesitancy, monitor adverse events, and really be able to bolster capacity at an operational level, not only in India, but even learn from other countries in the region. So it's a mix of all of these efforts, but we hope that we'll be able to inch closer towards the equity that's truly needed in this pandemic situation.
Thank you. Thank you so much. The next question, I'll bundle it, goes to Dr. Williams and Christian. The question really is, there is a skepticism and lack of trust. What do you do to that population that refuses to get the vaccine, and how do you deal with that conundrum? Dr. Williams, and then Dr. Van Stolk.
Okay, thank you so much for that question. And that is the conundrum. And I think that really and truly the best that we can do is that we continue to create avenues for understanding and for education. Do we get to the point where we mandate vaccines? I think that is going to be the big question. And that is something that I think as a society, we're going to have to really entertain in the same way in which we have mandated a number of other vaccines in terms of being able to, whether kids be able to go to school, to be able to go to certain work environments where there are certainly vulnerable populations. I think that is going to have to be one of the considerations if we have any hope of trying to get to the type of herd immunity to protect the collective.
Yeah, thank you for the question. I think there's some direct things that we can do and which have proved quite effective. Targeted communications is obviously one route. For instance, if I take the example in the United Kingdom, where I live, is what we noticed is a lot of the public health information was in English, and there are certain communities in the United Kingdom that do not have English as a first language, so that was a barrier. But also what really became important is role modeling. So a lot of the public health guidance came from specific sources, which many of the communities could not relate to or did not trust. So the role modeling was really about finding channels that those communities engaged with, be it community workers, maybe celebrities that they looked up to from those communities, and so on. And that has proved to be quite effective in increasing the take-up of the vaccine. I think, coming back to the point around certification and proving your status in society, I think the hope of policymakers is that the need for this will go away as we get close to herd immunity. But as we heard from Dan, we need a bit of luck. So if there are new variants that come out and so on, and we get into another round of vaccinations, these COVID certification plans and so on, and COVID status might be here to stay, quite frankly. So policymakers are hedging their bets at the moment. They're sort of toying with these ideas. They're trying to see what they can do with this. On the other hand, nobody really wants to do it, but the reality is that's for political pressures, they may need to do it. And if they do this, then ultimately this will have equity, consequences, or in terms of how we think about equity. Not least the fact that because I've been vaccinated, I can perhaps go to a restaurant that somebody under the age of 30 will not be able to go to a restaurant. Seems a rather odd situation to find yourself in. And that's just an innocent example. I think there are potentially much more dangerous consequences of this as well. I think trust is a really important thing. And what I've learned from the European situation is that when politicians start questioning the efficacy of vaccines, start arguing with pharmaceutical companies, the results are not pretty. So we need to be steadfast in being behind the vaccines. Clearly, there are issues with the AstraZeneca vaccine and with the Johnson & Johnson vaccine in the US. but the benefits by far, and I will defer to Dr. Williams on this, but the benefits by far outweigh some of the risks that are involved with this. And that's an easy calculation for me to make as a researcher at the RAND Corporation. It's much more difficult, sort of judgment to make when you don't have access to the information that I have access to, and you might be distrustful of governments that have not treated you particularly well over the years. So that is the absolute lesson. Politicians should be unwavering in their support for these vaccines because they're the way out, and that I think is pretty clear from the statistics that I see here on a daily basis in the United Kingdom, where the tide is clearly turning.
Thank you. There is one final question for Dr. Kress, but I might, given the shortage of time, I might just pose it and have you deal with it then as part of your closing remarks. And the real question is that COVID has shown the concentration of manufacturing capacity within a few countries and the fragility of the global supply chains. Does it call for a different way to structure supply chains, manufacturing, and the financing, not just of vaccines, but pharmaceuticals more generally? Okay, so that's a big question to ask for your concluding remarks, but I'm going to now turn it over to Dean Madison for the last part of the discussions. And from my side, thank you so much to each one of the panelists for your wonderful and very illuminating and profound thoughts today. Thank you.
Thank you, Professor Nanda Kumar. I noticed, I think that Dr. Williams, you unmuted, so I think you may also want to weigh in on what Christian van Stolk was saying. Is that correct? Do you want to integrate that into your closing remarks?
I will. Yes, I'll integrate it.
And if you'd like to go first, that would be wonderful. And as a part of integrating a little bit of what Christian was describing around trust and uptake, I wonder if anyone would like to, and this is on behalf of my students, describe the J&J pause where you see it. I know the ACIP decision and others are coming out today, but pausing when there are 6 cases among 6.8 million doses left quite a few people asking, we need more scientific information. Related to your presentation, Dr. Williams, is that we need to educate the population about the speed by which we were able to come up with these vaccines, and the more knowledge they have, the more there's trust. So given the strengths of a J&J kind of vaccine, 1 dose, longer refrigeration, et cetera, if you could also add that to your closing remarks. And we want to, give our other 4 panelists a time as well. Thank you.
Yeah, well, I'll say quickly in response to the J&J and the side effects and the blood clot issue. I think we have to be mindful of the denominator. So often we focus on the numerator, and we really don't pay attention to the real context of the very, very, very small incidence of those side effects and the not unexpected nature that there are going to be side effects. Do we need to understand the ones that seem to be lethal and that seem to have more dire circumstances or consequences? Absolutely, but I really want people to really pay attention. This is driven, I think the hesitancy related to vaccines is driven by fear. And this is part of the fear that people are concerned about. But the fear of what COVID itself, the manifestation and the long haul side effects of COVID far outweighs what we have seen in terms of real significant lethal and prolonged side effects of the vaccine. So I think I really encourage people to take that into consideration, and we will continue to learn more. I think transparency is very, very important. And as we continue to really hold the pharmaceutical companies accountable for sharing the data and sharing the information, but yet maintaining the context that this is a very, 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 very small numbers of these types of side effects. And in actuality, when you are essentially, the efficacy of this vaccine is based on an autoimmune response, which means it's revving up so many different types of cells within our bodies that in a certain subset of people, that kind of hyper stimulation can cause some untoward effects. In terms of my closing remarks related to what everyone has said, I think in terms of when we think about the equity and the issues of these social determinants of health, as an author, as someone who's deeply committed to really children's education and using education as a real platform for changing mindsets. When we think about the HEAL legislation that the Senator spoke about, is that we have to be very mindful of these embedded policies, beliefs, racist stereotypes comes from just centuries and centuries of messaging. And so we need to do the work starting with our children. The messages about the education and awareness of the history, and really creating a level playing field for resources for both for education, for knowledge, and for really bringing together an awareness of why equity is important, and having that literally be a part of our kids' and children's awareness from the time they open their eyes.
Thank you so much. I'm going to move over to you, Kress van Stolk, for your closing remarks, and then Dr. Patel. Kress, and then Sangita.
Yes, and I think I'll pass part of my question over to Dan as well, who will be pretty well placed to answer that, I think. So I think the reality is that every supply chain is global, right, in some ways. The problem that with this crisis is that, because of issues around nationalism, countries have started disrupting that supply chain for their own purposes, which has been kind of counterproductive. So there's two answers to that. It's either you can sort of build up a different type of supply chain, or you try to work as an international community to ensure that the global supply chain can keep working. So, I mean, I think there's two possible answers to the question that I was posed. But intrinsically, I think the argument that I take is very similar to the one that Dan put forward, in the sense is that this is really about partnership working and ensuring that vaccines become widely distributed across the globe and so on. And in order to do that, you have to keep the global supply chain going. And so any disruption to that is fundamentally problematic. So I think one of the lessons we need to learn is that all of the steps that were taken to disrupt the supply chains, be it by the European Union or by other countries, were in fact completely counterproductive. It didn't really help with the vaccine production in Europe. It didn't help with vaccine production globally. In a sense, also politicians start realizing that and undoing many things that they were putting in place. So there's barely any export controls in place at the moment in the European Union. So I think that would be the lesson for me. Whether it will happen again in the future, probably so, because I think humans take a little while to learn, right? I mean, we sort of we take a couple of times. So I think the lesson here is really the point that you kept making is really about partnerships, about global connectedness, trying to solve these issues together rather than at a national level.
Thank you so much. Dan, do you want to respond? And then we'll go over to Sangita.
Yeah, I mean, so a couple things I would say. I think when you look at the global supply capacity in terms of for vaccines, and I'm going to try to kind of answer the question that Nanda and Christian kind of put to me, but also there was one in the chat that I'm going to try to link to as well. There is. If you look at it, if there obviously are a lot of vaccine manufacturers kind of in the global north, if you will, in the OECD countries, in the US, Canada, Europe. There are quite a few, India, as I mentioned previously, has a number of manufacturers that are really of global importance, of national and global importance. And, Serum Institute for India is probably the premier one. But there's also, Bharat and several others, Dr. Reddy's, and so there are some other manufacturers in Brazil, in South Africa. There's even some manufacturers in Cuba. Ironically enough, one of the countries I worked in when I was at the World Bank was Iran, and Iran is not well known. Iran is actually self-sufficient in vaccines, largely. The challenge is, I think there's, globally, what's going to happen. There's a couple of big issues. One is the capacity generally in Africa is quite limited, and there's been a lot of interest and a push now to try to think about how to build capacity to manufacture vaccines in Africa. And that's actually something that the Africa CDC, and there's been some work with the USAID has been looking at that as well to try to what we can do to support that. One of the big things is, again, mentioned previously, is the technology transfer. A lot of the, if you're trying to do something like an mRNA vaccine that's, quite complicated, there's a transfer of technology. You might have the capacity, but there's a transfer of technology that needs to be done in order to manufacture some of these more complicated vaccines. On the economic arguments, there was sort of questions about that, what can be done. And, in a way, I think, trying to come back to this message, I'm trying to be, I think there's sort of some good news here, is that, the global community has learned a lot because of Gavi. Gavi was a way for the world and the global health community learned a lot about how to use economic incentives and supply chain techniques to be able to actually kind of provide more supply security for vaccines. And then certainly with the pneumococcal AMC, Advanced Market Commitment, there was a lot learned in terms of how you use economic incentives and financing structures to be able to accelerate the introduction of vaccines for the developing world. And that was really what the challenge was. With the pneumo AMC, it was a vaccine that the US and the OECD countries had introduced some time ago. But in the US, the CDC price was like $121 a dose. And it wasn't optimized for developing countries. And what the pneumo AMC did was create a mechanism that kind of helped develop a formulation that was better indicated for the low and low middle income countries, as well as accelerated that, and then also dealt with the issue around cost and sustainability. Because it's some of the issues around even just aggregating. One of the, I think, the innovations with the COVAX was this COVAX facility, which was really trying to aggregate demand through this pool purchasing. What it really does is it provides greater predictability and certainty for manufacturers around what's the nature of the funded demand. Because oftentimes in global health, we've been want to kind of talk about needs, but not really about what the funded demand is. And what manufacturers want to know is what can we actually sell? And then they'll plan production for that. And one of the good things is when you do that, vaccine manufacturing tends to be very much characterized by economies of scale. And so if you can get large volumes, you can actually get much lower prices as well. So I think there's been a lot of learning globally, and Gavi and the global community have gotten quite more sophisticated about using these economic tools and approaches. And I think industry has been a great partner in that, and have been very happy to, to work within that context and that structure, because it works with them. It works with the kind of some of the incentives they have. I'm sorry for that long response.
No, thank you so much, Dan. We want to hear from Sangita, and Senator Comerford will take us out. Thank you.
Thank you so much. So I think from my end, as I reflect upon what's been discussed and also look to the future, I think that what's really cogent for me, especially in what stands out, is that a lot of what we've talked about so far in this panel has been about response and really recovery, especially through vaccines. And I think for me, what is the resounding message as well is that notion of preparedness. And I think that if we look globally and we consider where we are today, obviously, it took us 102 years since the Spanish flu to encounter something of that magnitude yet again. But it doesn't mean that it won't happen again. For me, when we look along that preparedness continuum of prevention, of protection, mitigation, response, recovery, to me, what clearly is a message is that we do need to reinforce investments in global health security and really being able to ensure that the foundations that are weak, the health systems, are ultimately strengthened. Because I know even we've heard many times that, even comprehensive primary health care and global health security are really flip sides of the same coin. that ultimately these are the kinds of foundations that it will take to allow us to be more resilient and responsive for the next threats. And I think what's sad is that, as we look at, bolstering, supply chain or manufacturing or financing, we'll do it in an emergency manner, in a global manner, in an interconnected manner with the institutions that you've already heard about, or even specific innovations within countries. But I think it's a resounding wake-up call for all of us to relook at global health security, at how we will have a transparent means to reinforce that we've got to have that foundation and capacity across countries, ultimately to be able to spread or to control the spread, if you will, of infectious diseases. Otherwise, we'll simply end up in this sort of vicious cycle. So for me, while vaccines are a priority, I do think that it's secondary to ensuring that that global health security agenda is not forgotten.
Thank you so much. Global health security and a global sustainable infrastructure. Senator Comerford.
Thank you so much. This has been so valuable for me to be rooted here in Massachusetts with a virtual room full of global thinkers. This is very, very powerful. I want to pick up where Director Patel was talking about in terms of preparedness, because as you talk about it so beautifully at a global level, I'm realizing that that is one of the main charges here in Massachusetts. So that's a connection, right? A Massachusetts to global connection. Another connection I heard today was equity. The Commonwealth is so laser focused on equity, and to hear that message being echoed around the world, if you will, is pretty profound as a call to action for a way we respond. Recently, Dr. Sandro Gallia from Boston University briefed the legislature, and he said actually a pretty profound thing at the end of his talk. He said, look, we have a couple of choices. We know it's going to happen again. We know we'll face the next contagion, the next emergency, and this gets back to what Director Patel was just saying. So we can do two things. We can write the chapter now for the next contagion, the next pandemic, just put it on the shelf, save ourselves the trouble, or we can actually do what needs to be done to be prepared, to focus on equity, to write a new chapter going forward. We can, and he's of course suggesting that we do just that. And one of the things that Director Patel talked about as well was just the focus on the most affected in the labor force as we talk about the entire recovery. And here in Massachusetts, women, essential workers, women of color especially, have been the hardest hit in terms of job loss and increase in poverty. And to see that echoed globally again is quite profound, but it also just, I think, should urge us on here in Massachusetts to understand that what we take up in the name of writing a new chapter is reverberating in nations across the world. And then the last thing I'll just say is, going back to what Dr. Williams was saying about radical transparency and the fact that this is going to change so many times, that we are building a road as we sprint down it. And so the responsibility of policymakers, the responsibility of thought leaders to communicate in such painstaking ways that builds trust, builds pathways toward breaking down barriers to vaccine hesitancy, toward creating new policies that are actually part of a future that's more just, is so profoundly needed. It's been one of the challenges here in the Commonwealth, and it just to hear that call to action just again strengthens, I think, what we have to do here in terms of really communicating equitably as an action of policy. So thank you so much for this opportunity.
And thank you for those closing words. I want to thank each of you. I hope we can meet again in the next 100 days and see how we've moved the needle on everything that you've raised so beautifully today. I want to thank our audience as well as our organizing team. And with that, thank you, everyone.